You are welcome to our platform of teaching session in Department of Urology, SMS Medical College, Jaipur. So today we are going to have a case discussion on pelvic fracture pelvis urethral injury. And this will be presented by our first year resident, Dr. Gaurav Fosdar. And it will be discussed with the third year resident, Dr. Sanjay Yadav. The case would be moderated by Dr. R.D. Sahu. And we have three special invitees with us together today. So we have Dr. Rajesh Tiwari. Dr. Rajesh Tiwari is a professor and head of the department at Indira Gandhi Institute of Medical Sciences, Patna. So Dr. Tiwari, you are most welcome to our platform. And we are really privileged to have you. Then the second invitee we have is Dr. Gautam Banga, who is a director at the UPS Center for Reconstructive Urology. He is also SMS alumni. Dr. Gautam, you are most welcome to our teaching session, and thanks for coming. And the third invitee is Dr. Santosh Singh, who is, again, he was ex-professor and head of the department at Rohtak Institute of Medical Sciences, and he would be probably soon joining. So we will start with Saraswati Vandana.
Saraswati Namaste Varde Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
So thank you all of you. So once again, welcome to this teaching session. So I would request now Dr. R.D. Sahu to kindly moderate the session and invite the present.
Good evening, sir. I am audible, sir.
Yes,
am I audible, sir?
You are audible.
Good evening, my teachers and my colleagues. Now I am invite Dr. Gaurav to share the slides for the case. The case will be discussed by Dr. Sanjay Yadav. He is our third year resident. Please start.
Yes, sir. Good evening, everyone. Today we are here to discuss a case of 28-year-old male presented with complaint of unable to void per urethral following a road traffic accident 6 months back. In the history of present illness, patient had run over injury while crossing the road 6 months back. Patient was clinically stable at the time of injury with complaint of unable to void with suprapubic fullness and blood at the meatus. One gentle attempt for catheterization was tried but failed, and then SPC was done. Since then, patient was in SPC catheter, which was changed monthly, and patient has bilateral SPR and IBR fracture, which is managed conservatively. No other injury was present, and the patient was discharged from the hospital after 3 days with advice of bed rest for 6 weeks. And then patient came regularly for SPC change, and at that time, erection was normal and ejaculation was completely absent, and patient is able to walk normally. Now come to negative history. No previous history of voiding difficulty, no history of flank pain, fever or purulent discharge, no history of testicular pain, scrotal swelling, penile or glandular lesion, no history of decreased urine output, nausea, vomiting and pedal edema. In past medical history, patient is known case of type 2 diabetes mellitus since last 8 years and on oral hypoglycemic agent. No history of hypertension, tuberculosis or any other comorbidities, and no other history of any drug allergy. In personal history, patient is a smoker since last 20 years and consume 20 packs per year. Patient is non-alcoholic and no history of any drug addiction. Patient has normal bowel habits and sleep cycle, vegetarian by diet and laborer by occupation. In family history, patient married since last 3 years with 1 children alive.
Gaurav, stop please. Dr. Sanjay, anyone wants to Dr. Sanjay.
Good evening, sir. I would like to ask any past history of surgery.
Well, I want to ask about one thing.
Any surgery or
Excuse
intervention.
me, just Dr. Gautam is going to give a comment. Yes, Gautam, please go ahead.
They mentioned that the patient was having a normal erection. So just want to know how it was checked.
So, Gaurav,
Yes.
how did you know that he had normal erections? Was
Sir,
it a history given by the patient? Yes.
yes, a patient gave history that before the trauma and after the trauma, patient has the same erection.
Okay, so what kind of erection? He's unmarried, right?
It's a married since last 3 years, sir.
Okay, he is married, so he is having normal erections, he said, nocturnal or early morning erections, right?
Yes, sir.
Okay.
Verified during the examination? Are you going to come to that?
Gautam, yes?
So it was verified with the examination and some other investigation. So that will be covered later.
Achha, that will be covered later. That will be covered later, whether we have investigated for erectile function or not, that will do. So at present, the history, anything else Dr. Sanjay wants in the history? And then we will ask our invitees to give their inputs. Sanjay, you want any other history?
Sir, in the past history, I want to like any history of any surgery or any instrumentation.
Gaurav?
Sir, there is no previous history of any surgery or other instrumentation of urethra, sir.
Okay.
Yes.
Anything else, Sanjay?
Any history of blood transfusion?
Yes, Gaurav?
Sorry, sir. Blood transfusion.
Okay, so there is no history of blood transfusion. Fine. Sanjay, anything else?
Then everything
Okay,
is
so
written.
briefly summarize the history in 2-3 lines, and then we will ask our invitees if they want to add something or if they want something more from the history from our examinee or the residents. Yes?
Yes, sir. Sir, basically 28-year-old male presented with the history of road traffic accident 6 months back with the history of the SPC in situ, and there was no negative any other surgical history or any intervention with the diabetes mellitus.
Okay. So, Dr. Rajesh, Dr. Santosh, and Dr. Gautam, anything you want to add that the residents probably have left, or they still they need to complete the history in any way?
No, to me it is all right. Okay.
I just want to know whether he is able to walk properly or with a lame.
Right. So a very important point pointed out, the gait of the patient and any kind of whether he is able to walk normally or not. Gaurav?
Yes, sir. Sir, patient is able to walk, sir, normally.
Because he had a fracture, and he had a fracture which was treated also.
Yes,
so Dr. Sanjay, Dr. Gautam rightly pointed out, why do you think it is important?
So because at the time of surgery, if there is any difficulty in walking, then I have to go for orthopedic consultation.
Okay, so it's very important because you have to do the surgery in a lithotomy position. So you have to actually not only see whether he is able to walk or not, but he actually can squat, or can you do a proper lithotomy position or not in this patient who has a fracture also. It's very important. So very important point. So I would request the technical support to please reduce the disturbance.
Yes,
technical
sir.
support team, Ashish, please reduce the disturbance. Yes. Okay. So Gautam, you rightly pointed out. Anything else?
The site of the SPC, that is also very important.
Wow, great.
Yes.
So that's Sanjay, why this is important? you didn't ask about the site of the SPC.
Yes, sir.
Why it is important?
Sir, because at the time of definitive surgery, it will help me during manipulation of that hair groove.
Right, hair
So
groove
it
dilators,
should be,
which will
at
pass
least
through the
3 to
posterior urethra, right? So what do you want to know exactly? Usually, what is the problem with the SPC site? When it is done in emergency by, suppose, a general surgeon or by untrained urologist or an untrained doctor, what problem usually you have with SPC?
So basically, if general surgeon or any other
No, don't
other
say
than
any
urologist,
anybody, even a urologist can do this mistake. But tell me, what would you look for?
so basically the position should be at least 3 finger breadth and it should be midline.
Okay, very good. So it should be central and it should be above. Usually it is at the anti-wall or dome of the bladder, it should be put. So it should be at least 3 fingers above the SP upper border of symphysis pubis, right? Anything else?
Yes.
Dr. Gautam, Dr. Rajesh?
Sir,
since
I think history is complete. We can check for the other things in the examination part.
Okay, fine. I will just put few comments about like this patient who has a road traffic accident, right? So he may be having other associated injuries also. So when you are giving the history, you need to ask the history of other associated injury besides the fracture pelvis. He might be having some head injury on which he is taking some treatment. He might be having associated abdominal injuries. He might have had some kind of rectal injury with the fracture pelvis. So you have to be very clear that he didn't have any other associated injury. So you need to ask a detail about other associated injuries in such a case of road traffic accident, right?
yes.
Besides that, you need to ask about like sometimes what happens if there is a rectal injury, the patient may be passing some little air through the sometimes through the rectum, and that is called kind of a passage of air or passage of urine through the rectum. So he might be having a fistula's opening also. So all these things are important while taking the history, right?
Yes.
Okay. So I think we can go ahead. If the Gautam, it's okay. Should we go ahead? All right. So go ahead, Gautam. Gaurav.
Yes, sir. Sir, now come to general physical examination. Patient is conscious, well oriented to time, place, and person, and cooperative. Average build and average nourishment. Gait is normal. Pulse is 94 beats per minute. Blood pressure 136 by 84 mm of Hg. Respiratory rate is 12 per minute. Body mass index is 27 kg per meter square, and temperature is 97.4 degree Fahrenheit. No evidence of pallor, icterus, clubbing, cyanosis, pedal edema, or any lymphadenopathy. On examination of respiratory system, cardiovascular system, and central nervous system, there is no abnormality detected. On per abdomen examination, per abdomen is soft, no ergonomegaly or lump is seen. Back and spine is normal. Hernial sites are normal. A 16 French suprapubic catheter present in the midline, 3 finger breadth above the pubic symphysis. On local examination, on inspection, meatus is normal, prepuce is retractable, no BXO changes are seen, glans and penile skin is normal, no abnormal discharge per urethra or from perineum, and no swelling or scar at scrotum or perineal region is seen. And then come to palpation, no local rise of temperature and no tenderness at penile, scrotum or perineal region is seen, no penile induration. Palpation of urethra is normal. Both testes present in the scrotum and the perineal sensation is normal, intact and normal. And come to digital rectal examination, anal tone is normal. Prostate grade 1 firm, smooth surface and non-tender. Bulbocavernous reflex is present.
Right. Just to stop there.
Yes, sir.
Yes. So Sanjay. Anything
Yes,
else?
sir.
Anything else you want in the examination findings?
Sir, on palpation of the local area, I would like to know the glance sensation, sir. It is cold
Glance
or clammy. Yes, sir.
Okay.
Whether it is cold or
Okay.
clammy.
Okay, so you think whether is a glance is numb or not? Numbness over glance. What is there in your mind? Why could it be
Sir, if
numb?
the patient had, sir, basically this can suggest that patient can have a vascular injury at the time of pelvic fracture, sir. Yes, sir. At
So
the,
vascular injury
either at the
would
level
cause
of
numbness. Vascular injury
sir,
would
either
cause
vascular injury
numbness.
or a nerve injury, sir.
No. So yes, so it could be a nerve injury, dorsal nerve of the penis if injured. There may be some numbness over the numbness. Yes. Dr. Rajesh and Dr. Gautam, do you want anything else on physical examination or anything you want to comment on?
What is about the temperature of the glance? If it is relatively cold, then it suggests vascular.
So we have to see both
Glance temperature.
sensation,
Right.
pallor, or vascularity of the glance. If the temperature is
Yes.
on, then
Then it suggests vascular injury.
Yes.
What are the common vascular injuries in pelvic fracture? Dr. Sanjay.
Sir, most commonly is internal pudendal artery.
Yes.
Is the at high risk of injury. Then superior gluteal artery at in the posterior pelvis at high risk of injury, and mainly, sir, venous injury are also common in these cases.
Yes, but pelvic venous plexus can be injured, and obturator artery and internal pudendal arteries, these are the two arteries most commonly injured in fracture pelvis. And what about the nerves? What are the common nerves which can be injured? Because in the pelvis, right? Yes.
Yes, sir. So cavernosal injury is very common, and the sacral nerves at the posterior sacral phenomena, these two nerves are at risk of injury, sir.
Yes.
Right.
Yes.
So Sanjay, this internal pudendal artery ends as into which branches? What are the two branches?
Sir, first it gives a scrotal artery or a perineal artery, then it become a common penile artery, which further divide into
Divides into yes.
Bulbourethral artery, dorsal penile artery, and cavernosal artery.
Yes.
Very good. And what about the nerves? So why do these nerves get damaged? At what is the site of these cavernosal nerves?
Sir, injury site, sir.
Yeah, injury site. Why these cavernosal nerves or the maybe even the penile artery or the urethral artery are prone to injury?
Sir, these nerve and vessels have to pass through the membranous urethra, sir, urogenital diaphragm.
Right. Yes, diaphragm, and then they enter into the corporal bodies, right? Posterolaterally, right? So when there is a urethral injury at that site, there is a chance that there is maybe a nerve injury or the vascular injury also, right? So that is probably the reason for erectile dysfunction in these patients. All right.
Sanjay, which type of fracture is more prone for vascular and neurogenic injury?
Sir, inferior pubic rami fracture, sir.
Dr. Gautam is asking, can you classify the pelvic fracture? How do you classify fracture pelvis?
Sir, pelvic fracture classified by two classification. One most commonly used tile classification, sir.
Yes.
In which divided into three category, A, B, or
right.
C.
Right. What is A, B, E, and C?
Depend on pelvic, sir. A is a stable fracture.
Yes.
There is no pelvic instability in case of A.
Right. Right.
In case of B, sir, there is the rotational instability, but vertically stable. And in type C, both vertically and rotationally unstable fractures are there.
All right. Right. So now comes
And the second
now
one
you
is
come to the
Young
question.
Burgers
Yes.
classification.
So which type has more chance of injury to the nerve and vessel? Type B and C.
So
right?
anterior pubic rami.
Yes, so yes, if there is a rotational deformity, then there is usually a pubic fracture, maybe unilateral or bilateral. That's kind of sometimes called an open book kind of fracture, right? And then the type C is also called Malgagne's fracture. Malgagne's fracture, when there is another vertical displacement in the form of either iliac bone injury or the sacral bone injury, right? So if there are displacement on the two fronts, both vertical and rotational, it would be type C, right? So which is more prone to, yes. Anything else?
Yes, sir.
Do you know what is the incidence of erectile dysfunction in only fractured pelvis and fractured pelvis associated with urethral injury?
वो तो सर आप नहीं बताओगे
Yes, sir.
Technical team, please reduce the disturbance. Technical team.
पैसे मांगने
Ashish.
उसमें आपकी जरूरत नहीं है.
Ashish.
Yes, sir. Yes, sir.
From technical team.
Hello.
मैं
Recording in progress.
So you are muted, sir.
Tell me, what is the incidence only pure fracture pelvis and fracture pelvis with urethral injury? Any idea?
Yes, sir. Basically, sir, incidents are vary in different studies, but we can say that in case of pelvic fracture only, it's about 25 to 30%, and in case of pelvic fracture urethral injury, it's something around 50%, sir.
I don't think so. In pure fracture pelvis without any urethral injury, the incidence is a bit lower. I think it's around 5%, 5 to 10%. And if there is a urethral injury, it would be around 40 to 50% kind of erectile dysfunction in these patients, right? Anyway, and anything else, Dr. Rajesh and Dr. Gautam?
No, I think it is all right.
I think we can go ahead, right?
With the investigation.
Yes, right. So, Sanjay, you are happy with the examination? Any other finding you want to know? So why do you do an actual neurological examination in this patient? Is it important?
Yes, sir.
Why?
Sir, because neurological examination will tell. Yes, sir.
Yes.
Sir, your neurological examination will tell me the integrity of that sacral nerve plexus, sir.
Okay. So there could be an injury to the nerve plexus also, and that can result in loss of sensation in the perineum and etc. Plus anal tone may be lax and all this. That's important, very important in terms of the management, right? Okay. I think we can go ahead with the what investigation you want, Sanjay?
Sir, first I will go for a urine routine and culture sensitivity, and then followed by yes, sir.
Followed by?
Followed by sir RGU-MCU, sir.
Okay, right, very good. So investigations usually we would like to have for clinching the diagnosis. So we need to first diagnose the case, and in that thing in perspective, you have to investigate further.
Yes, sir.
Dr. Santosh, is Dr. Santosh there? Santosh Singh? I think Dr. Santosh is not there. So, right. So go ahead, Gaurav.
Yes, sir. Sir, on urine examination, sir, pH is...
Sir, Dr. Santosh is there, but he is muted himself. Santosh, sir, can you unmute yourself?
Santosh, Dr. Santosh? Okay. If anybody can just call him and just unmute him, ask him to unmute. Anyway, we can go ahead, and this is a urine routine examination, and the culture is sterile.
Yes.
Why it is important, Sanjay?
So
Why did you ask?
the RGU, MCU.
Okay, so you need to, you want. Okay, fine.
If the culture is, yes, sir.
So you want to give antibiotics before doing an RGU if it is infected, right? Okay.
Yes, sir.
Fine. So show us the RGU.
Sir, this is the X-ray pelvis film, and then we come to sir RGU and MCUG film, sir.
Okay. So read it, Sanjay, and let our invitees, Dr. Rajesh and Dr. Gagan, then come in. Sanjay, please read your RGU film.
Yes, sir. So this is combined RGU and MCU film. In the upper films, sir, basically first I would like to comment on RGU. Contrast is well ossified in the anterior urethra up to bulbomembranous junction, and there is no abnormality in the anterior urethra, I can see. And in MCU film, bladder is well distended, no other abnormality like VUR or any diverticula is there, and bladder neck is not opening, sir. And with this combined RGU MCU film, the distraction defect is more than 2 to 3 centimeters most likely, sir.
Okay, so go back to the previous film and also see the plain X-ray KOB, right?
Yes, sir.
So here, anything you want to know?
Sir, in this X-ray pelvis with both hip joint film, there is bilateral inferior pubic rami fracture and also bilateral superior pubic rami fracture is there. No bladder stone is there, sir. Or sacrum is normal, sir. Other bony landmarks are normal, sir.
Okay, which type of fracture pelvis then?
So this is known as straddle fracture, sir. Straddle fracture, sir. In type, yes, sir.
Why straddle?
So because
straddle injury is something which is called perineal injury, right? Where the injury is to the perineum. This is you have yourself said about this, the types classification, it will be type B classification, right?
Type B.
Anyway,
Yes, type
right, right. Dr. Rajesh and Dr. Gautam, I would like you to just comment and ask any questions to the resident, please.
Sanjay, these RGU MCUs are done by you or by the technician?
Sir, these are done by us, sir.
Okay, so how you follow this? So how you go ahead with the RGU MCU?
Sir, first the patient position should be supine and 45-degree tilted. Then the ipsilateral leg should be flexed and the opposite leg should be straight. And under aseptic preparation, 5 to 6 French Follies inserted inside the meatus and inflated with 1 ml normal saline, and with and it should be held at moderate traction, and with the help of iodinated contrast, with the slow installation of the contrast, I can do, sir, RUG.
When we're doing combined MCU RGU, we always do MCU first. We want the bladder to be full, then only we can get because you cannot keep a hold of the urethra till the bladder fills up. So it's better to fill the bladder first, okay, and then you tell the patient to strain, and simultaneously you inject into the urethra, anterior urethra, so that you can get a combined MCU plus RGU film. Okay. So do you give any medication so that the bladder neck can get open? Do you give him alpha block or something like that?
Yes, sir. Sir, one night before that procedure, we used to give alpha blocker. Tamsulosin, sir.
What kind of dye you use and what the concentration, how you dilute it? Like just because there are first year, second year, so they are going to do it. So just they should know how to do it.
Sir, it is a sodium dihydrogenate, sir. 76% solution, sir.
That's a you're talking about.
Yes, sir. And we used to install 10 ml in 100 ml, 10 ml of the whole that ampule diluted in 100 ml normal saline.
Okay, but that will give a very dilute kind of picture. So we always give around 25 to 30 ml in 100 ml, so that give a much better picture. That. Yeah.
Okay.
And anything, yeah. Dr. Rajesh?
Is it appropriate, RUG? Dr. Sanjay? You told
Yes,
me that
no.
it should be in 45-degree oblique position. Is
So,
it
very, very rightly pointed out, Sanjay. Do you think this is an oblique film?
Yes, sir. No, sir. Sorry, sir. Because both the obturator foramen are clearly visualized, sir. In this film. There is not proper oblique, sir.
Yes. So it's very important. And how does it actually? See the ureterogram, RGU. In the RGU, you are not able to see the whole of the bulbar urethra, right? So this is a slight overlapping of the bulb is also happening here. Probably the stretch was not proper and the obliqueness was not there. So that is why you are not able to see the whole of the bulbar urethra probably. That may be the reason, right?
Yes, sir.
Can you comment about the bladder neck?
Sir, bladder neck is closed in this MCUG, sir.
What does it
You said RGU MCU, and can you go ahead with the surgery with this RGU and MCU?
With this, sir?
Yeah. Can you plan the surgery on the basis of this RGU and MCU, or you do something else to define the things in a better way?
Sir, basically, bladder neck is not opening in this case. So I can repeat, sir, RGU MCU, sir. Basically, MCU, sir. And RGU also, because positioning is not proper. Otherwise, I will go for surgery, sir.
Okay, without knowing how much is the defect between the...
Why? Yes.
Yes, Dr. Rajesh, yes.
Why it is important to know about the health of bladder neck? You can proceed if you are not doing it.
Sir, bladder neck, if it is open, then contrast will occupy the posterior urethra and it will give me the exact length of the dissection defect, sir.
So one thing
I
is
can
that
plan my...
So one thing it is will give you an idea about the gap. What is the importance of knowing about the gap? Anyhow,
it will...
You can repair it.
Sir, difficulty of my surgery will be, I can know, sir. Previous, yes, sir. Proactively, I can know, sir, the more step I needed or not, sir, during my surgery.
What is the limit? What should be the gap when you can perform the surgery easily by simple steps?
Sir, up to 3 centimeter, I can do simple perineal erythroplasty. Sir, if more than 3 centimeters.
Have you heard about any index?
Sir, there is a gapometry index, sir.
Yes.
So what is that? Tell us.
So gapometry index is a ratio between the dissection defect divided by the total bulbar urethral length, sir.
Okay. So what should be? It should be at least more than. If it is more than
1/3 or 0.3.
Okay, 0.34. Okay.
Again, coming back to the same question, what is the importance of knowing about the bladder neck? Why you want to know about the bladder neck health? Why bladder neck has not opened? What are the possibilities?
Sir, maybe the patient, 2-3 reasons are there, sir. Patient may be anxious during the time of MCUG. So that's why he is not able to properly relax. And the second one, maybe bladder neck injury was there. So bladder neck got scarred, sir, and it is not opening.
Not opening.
So which one is more common? Which one is more common? So like when you have a smooth lining of the bladder and there is no irregularity at the bladder neck area, so what do you think? Can it be a bladder neck injury?
So more likely it is an anxious patient.
Okay, he's not able to open the bladder neck. So in such a case where you have a smooth lining and the bladder neck is not opening, you are rather happier, right? Happy in the sense that you almost exclude a bladder neck injury in such patients. A total occlusion of the bladder neck with bladder neck injury is very, very uncommon. It's very uncommon and you will not find. And at least you will have some type of irregularity or some contrast going down into the posterior urethra if there is a bladder neck injury, right? So this is because the bladder neck is not opening, right? So you were asked, how would you know the distraction defect in this patient then?
So exact length of the restriction defect, I can order the MRI, sir, pelvis, for the exact length.
No, but usually what is the routine method that you adopt to know that? Because this is a very common thing that you come across, right? That the bladder neck is not opening. Almost half of these patients, you will not have the bladder neck opened, even with alpha blocker. So what is the usually you do routinely? Do you do a MRI in every patient?
No, sir.
So what do you do? Tell us. How do you know whether the bladder neck and the posterior urethra is normal and the distraction defect could be this much? How do you know that? What are the other ways to know it?
Sir, on RGMC or any other?
Anything. How do you do? Sir, how do you do it?
So before we can do, sir, antegrade and retrograde scopy, sir.
Okay. Yes. So up and down scopy. Yes. Usually that we do before the definitive surgery. Anything else?
Yes.
Anything else?
Sono, sir.
Sonography. Sonography how will it tell exactly the posterior urethra? Usually very difficult to know unless the patient opens up the bladder neck and all. So to know the distraction defect, it would be difficult.
CT, sir. CT cystography, sir.
So have you heard of boujogram? What is boujogram?
Sir, from above and below, we pass the bougie.
Right.
Under C-arm.
Yes.
C-arm, we can see the
distraction. Right.
Okay.
That's
easier way to know the distraction defect than an MRI. Much cheaper, and you can do it at the time of RGMC also.
So anything else, Dr. Rajesh? And yes?
No, it is all right.
Okay. So go ahead.
Yes, sir.
So let's show the other investigations. Yes.
So, then we go for blood investigation, sir. Hemoglobin is 11.7, sir. Total leukocyte count is 8,000 per cubic mm, sir. Platelet count is 295,000. Sir, blood urea is 17 milligram per deciliter. Serum creatinine is 0.89 milligram per deciliter. Serum sodium is 139 milliequivalent per liter, and potassium is 4.38 milliequivalent per liter. Random blood sugar is 102 milligram per deciliter. Serum bilirubin is 0.75. Bleeding time is 2 minutes and 5 seconds, and clotting time is 3 minutes 10 seconds. Prothrombin time test is 12.5 seconds and control is 11.7 seconds, sir. INR is 1.05. Urine routine and microscopy is normal, sir, and urine culture sensitivity, no growth detected, sir. And then come for up and down scopy, which is done by 6.5 French urethroscope. On urethroscopy, meatus is normal, sir. Anterior urethra normal. Complete block of bulbomembranous urethra. On downscopy, sir, on bladder, bilateral ureteric orifice are seen. Mild to moderate trabeculations present, and no space occupying lesion or calculus was present. And scope can be negotiated up to varus.
Can I ask a question? Why 6.5 French ureteroscope for hysterectomy?
Yes, Sanjay.
Sir, in structure cases, we used to use a small caliber scope, sir.
Not a stricture, this is an injury with a complete obliteration.
So
Yes,
this is a case of PFUDD or PFUI in a better term. So in this case, you want to know the anterior urethra. So how does a 6.5 foot help you? You can do with 7.5, you can do with 9 French ureteroscope also. So why do you want to take a 6.5?
That's not a problem. You can always do that with the normal 17 French, 19 French, because you have to just see the black.
Even a cystoscope you can do. At least the antegrade, right?
Yes, sir.
And what about the downscopy? What you use, a flexible or a rigid one to do a
rigid ureteroscope, sir.
For downscopy.
So can you get
for downscopy? Yes, sir. Rigid ureteroscope.
Okay, so is it always comfortable for you to reach up to the with that?
No, sir. It is difficult beyond the bladder neck, sir.
Yeah. So it can sometimes lead to damage to the bladder neck if we are trying to negotiate it past bladder neck in some cases. So it's always better to use a flexible scope, and so that you can go all the way up to the site of obliteration.
Yes, sir.
All right. So now you have every investigation and everything. Now, what do you think? What do you think it could be the defect like?
I will plan for.
Yes. So what do you think the defect is? So there is a block at bulbomembranous junction. All right. So now can you exactly tell us the defect size now?
Sir, it is less than 3 centimeters. Sir.
How do you know that?
So because the proximal limit, as the report told, bulbomembranous junction, and the proximal limit is up to Viru, sir.
No. So can you measure it on the X-ray of the retrograde urethrogram that you have? So go back to the RGU. Go back to the RGU. So now tell us, where is the bulbomembranous junction would be?
The bulbomembranous junction is the imaginary line at the lower border of occlusive phenomena.
All right. So where is it? So first of all, it is not a proper film, not an oblique proper film, so it may not be possible to exactly measure. But anyway, so the lower border of the obturator foramen, if you draw a straight line joining the two, that will be almost the bulbomembranous junction. So you can measure that defect. Yes.
Yes.
So this is not a kind of very long defect. This is maybe around 2 to 3 centimeters, as you said. Yes, fine. So you said about the MRI. In which cases MRI is important? MRI pelvis.
There are certain indications for the MRI, sir. It is indicated in complex cases, sir. Like, sir, if previously failed cases, if the PFUI is complicated with any fistula or a bladder neck injury or a rectal injury, and in case of, sir, we suspect long distraction defects, sir, more than 3 centimeters, then MRI has a role, sir.
Okay, so if there are cavities, there are fistulae, there are sinuses, and then the long distraction defect, a bulbourethral necrosis, a redo case, all these we would like to do MRI to actually delineate the whole thing, a type of injury the patient is having. All right. So in this case, Dr. Rajesh and Dr. Gautam, do we need any other investigation?
No, I do not think so.
Okay, fine. So I think you can ask them question about a resident, how they will go ahead.
So how will do the management? I think this is the stage when you have to see the lithotomy position of the patient, whether he is able to do the lithotomy or not. You have to see in the ward itself before subjecting the patient to the. And how will you need any special preparation before going for operation in these patients? or just routine?
Anything, yeah.
Sir, oral cavity.
No.
Pardon?
Why do you want to know the oral cavity in this case? Dr. Rajesh, what is in your mind? Just tell him.
So patient must not be constipated. Bowel must be clear. Rectum must not be loaded. So give a laxative and arrange blood because it is a PFUI. So
Yes, sir.
bleeding may occur. Even knowing about the gap, you may have to go for, it is not very indicative, some authorities and even in our experience, we sometimes have to go for more steps. So blood must be arranged beforehand. And you should look for the lithotomy position, and then you can subject the patients. And you must counsel the patients, because the counseling part is very important in PFUI. Because your operation may fail, restructuring may occur, or some other complications may occur. So you must brief the patient about the problem, the management which you are, operation which you are going to do, and the possible complications and the possible result in your hands or in the at your center, what is the result in the previously operated PFUIs. So you must prognosticate the patient and counsel the patient to avoid later problems, social problems and legal problems. So these things you have must, and you must ask, because he's a young patient, so erection part you must guarantee that he is not having erectile dysfunction beforehand. Bladder neck is competent. Why we are asking again for the bladder neck competence? Can you tell something about the significance of bladder neck in such cases?
Sir, if the bladder neck injured or hello.
Yes,
the
go ahead.
Sir, if the bladder neck is injured or incompetent, then after surgery, successful surgery, patient may have a problem of incontinence, sir.
Why?
So because in PFUI, mostly the that external sphincter is mostly damaged, sir. So
Yes.
the continence solely depend on that bladder neck, sir.
So how you suspect bladder neck incompetence beforehand? So that you can,
in case,
not in this case, in other cases.
sir, when we do that MCUG, then the shape of the bladder neck can tell to the some extent, sir. If it is open or funnel shaped, like, then it is mostly, sir, not sure, sir, but it more likely suggestive of incompetency.
So
and during
if in both the static and the dynamic film, bladder neck is open. If the bladder neck shape is rectangular, if there is associated neurological injuries, then you must counsel the patient about the possibility of incontinence, even after successfully giving a good urethra, good normal caliber urethra. So these are the things we must counsel.
One thing,
very important point pointed out that in both the films, if you have the bladder neck open, even when you are in the filling phase of a cystogram, you find that the bladder neck is open and the dye is going into the posterior urethra, then you suspect either bladder neck incompetence due to neurogenic injury or bladder neck injury itself, which could be the cause of incompetence, right? So very important point, yes.
So in PFUI, counseling is very important beforehand, before operation.
So anything you would like to do for the erectile function beforehand? Because many times the patient may not be able to tell you exactly whether if their erections are normal or not, right? So what would you do to confirm?
Sir, if the patient preoperatively have erectile dysfunction, then penile Doppler I can order to the patient, sir.
Dr. Shivam, sir, I want to put a
Yes, Gagan. Yes, Gautam, please go ahead.
Since a patient always give a history that they are getting erection because they don't want to hide, they don't want to show that they have erectile dysfunction. So we always tell the patient to click a picture when they're having an erection with the SPC along with that. So we can see whether the patient is having an erection after the injury or no. That's one way. If the patient claims that he is having a normal erection, you can always tell them to take a sildenafil and see whether they are getting erection. You can always tell them to stimulate the penis and see that. And if they don't get it, then we have to go with the color Doppler.
Right, a very, very important point pointed out. See, many of these patients may not have good erection. They might tell you that, no, I am having good erection. And after the operation, they will tell that I am not having erection after the surgery. So to confirm that they are having a normal erection or not, it's a very practical approach to ask them to get a photo clicked with the erect penis. After getting, maybe they can just take a sildenafil tablet and masturbate themselves and get it erect, right? So it's a very valid point. Because penile Doppler may be sometimes very fallacious. So in a normal, with normal erectile function, also the penile Doppler may show abnormal findings, right? So it is not very appropriate in every case. But this is a very practical point that he has pointed out, right? Anything else? So at least you need to confirm that his erectile function is normal beforehand or not normal. So if it is not normal, suppose, anything else you would like to do?
Then we
so you do a penile Doppler. Penile Doppler, what would you like to see in the penile Doppler?
Sir, in penile Doppler, I to look at peak systolic velocity of the cavernosal artery, and that resistance index, or resistive index, and diastolic flow, sir.
Okay. Which is the commonest cause for erectile dysfunction in such patients?
Sir, most common cause is mixed, sir, neurogenic and vasculogenic. And out of these, neurogenic is more common.
All right. So how would you know that this is there is a neurogenic cause?
Sir, if patient have normal nocturnal
erections, so that means what?
Sir, that means it is a psychogenic basically. It doesn't rule out, sir, organic cause. It just rule out psychogenic.
It rules out psychogenic if they have normal nocturnal erections.
No, sir, sorry. It includes, sir. It is suggestive of psychogenic.
So if they have nocturnal erections, that means it is probably psychogenic, right? Right. Okay.
Yes, sir.
And if they do not have even nocturnal erections, then probably it could be due to organic reasons. It could be neurogenic, and neurogenic can be done. If you can do a diagnostic intracavernosal injection test to know if they have a good erection with a small dose of bimix or trimix. That means probably the reason is neurogenic. And if they have not a good erection and it requires a higher dose of bimix, then probably it is a vasculogenic. Right? Yes.
Yes.
Anything else, Gautam, Dr. Rajesh, and Dr. Santosh? If he has joined, please come in. Dr. Santosh Singh. Okay. So Gagan, Gautam, and Dr. Rajesh Tiwari. Anything else you want to know here? Or okay. So let's go ahead with the what will you do? Yes.
Sir, I will plan for definitive surgery after explaining the patient of the pros and cons of the surgery, and I will go for progressive perineal erythroplasty, sir. Okay.
Okay. So, Gaurav, what was done? Just show him.
Yes, sir. Sir, in treatment part, sir, progressive perineal erythroplasty was done. Steps were complete bulbar urethral mobilization is done, then crural separation is done, and then inferior pubectomy is done. And then, sir, in post-operative period, liquid diet allowed from post-op day 1, and on post-op day 3, dressing done, and on dressing, wound is healthy, and then patient discharged on oral antibiotics, sir.
Dr. Rajesh and Dr.
Yes. Under what anesthesia it was done? What was the anesthesia? Pardon? Anesthesia?
Gaurav, tell us which spinal anesthesia.
Spinal anesthesia.
So let's go one by one. Which type of lithotomy was given and which is actually preferred?
Sir, we used to give social lithotomy position, sir.
Okay. So have you do you face any problem in that, or you want to go with the exaggerated lithotomy position? What are the benefit and the drawbacks of each?
Sir, sometimes in social lithotomy position, access to that proximal segment membranous urethra is difficult, sir, sometimes. But we don't have any problem in use our department, sir. We used to do, sir, that social lithotomy position because the exaggerated exaggerated lithotomy position have its own drawbacks, sir.
Okay.
What drawbacks? What drawback?
Sir, basically, it put the patient on the nerve injury, sir. And if it is for more than 2-3 hours, then the patient had a risk of that compartment syndrome and thromboembolism also.
Which nerve? Which nerve?
Mostly common peroneal nerve is at the
Okay.
And second thing is which incision was given and which incision should be preferred, and what are the options for the incision?
Sir, we used to do, sir, vertical midline incision in the perineum.
Okay.
From the base of the scrotum to the just before the 1 centimeter proximal to the anal wall.
So in all cases, this incision.
And other incisions are, sir, lambda incisions, S-shaped incisions.
Okay, so in which cases you prefer lambda incision?
Sorry, sir?
In which case you will prefer a lambda incision?
Sir, if I suspect that I need to have more difficulty during surgery, sir.
So you're thinking that the defect is too much, or if there's a bulbar necrosis, redo surgery, then you're planning. So you prefer giving a lambda incision so you can take a flap in case it is required.
Right. So the complex kind of urethral injuries, right? Yes.
So
Yes,
you mobilization, how you can explain complete bulbar urethral mobilization? What exactly is that?
Sir, the procedure?
Yes.
End of the urethral mobilization when you talk about complete bulbar urethral mobilization.
Yes, sir. Sir, the extent of the bulbar urethral mobilization, complete bulbar urethral will be.
Yes. What is the extent? What is the extent?
Pinoscrotal junction. Pinoscrotal junction.
How do you identify that it is pinoscrotal?
Sir, from the proximal limit of the incision, we insert a finger, sir, and feel the pinoscrotal junction, sir.
By keeping the penis erect.
Erect, yes, sir.
So before starting the lower dissection, do you put a hay groove in the suprapubic tract and try to feel it at the perineum? Do you do that as like a routine thing? Whether you can really feel the sound of the dilator in the perineum? Does it help you in some ways when you do the dissection or when you plan the things?
So proximal dissection.
Yes.
Sir?
So do you
definitely, sir, help in the sir, for the proximal stand, hay groove will be, sir, very much helpful, sir.
Yeah, so that gives an idea
of scar excision and the.
No, rightly pointed out that the first step after anesthesia and positioning should be the assessment of its PFUI on the table itself by passing the head groove from above and a catheter 14 French or 16 French catheter from meatus, urethral meatus. So first step should be in any stricture case, anterior, posterior, that assessment should be on the table itself. That will give you the exact idea of the stricture rather than the previous investigations, radiological investigations. So you must pass the head groove and then feel it in the perineum, whether it is palpable or not, whether you can feel it or not. Does it give you any idea that the operation is going to be simpler or going to be difficult? If you are able to palpate in the perineum, then it means that the gap is shorter. You will manage it from the perineal root itself. Sometimes after giving the incision, then after some dissection, you can feel it. And then it means that it is going to be by the perineal root itself. It is going to be managed. Otherwise, if it is not palpable, even after excision and a dissection of the proximal urethra, then it means you may have to go for the abdominal perineal. So some practical idea you can get by the head groove. I would like to have comments from other faculties.
Yes, very true.
Very rightly said, because if you are not able to feel the head groove dilator in the perineum, so there is a chance that the fibrous tissue is more deeper, and it would be you need to excise a lot of fibrous tissue before you reach the proximal extent of the urethra. So sometimes you may require even a perineal-abdominal approach, which is usually uncommon, but yes, you may require some. So it is important and very rightly pointed out. Anything else? So that is called PAPA approach, right? Perineal-abdominal approach. Rather, when you call a progressive perineal, it is PPU, right? That's a PAPA approach.
Yes.
Okay.
So you mobilize the bulbar urethra. What are the steps in mobilization of the bulbar urethra? What bleed vessels you have to take care of while mobilizing the bulbar urethra?
Sir, in the
bulbar urethra is supplied by
distal extent, bulbourethral artery, sir.
Bulbourethral artery, yes.
Bulbar urethra.
So
Yes,
proximally we have to take care of bulbourethral artery, sir. And in the distal part, sir, the perforators from the cavernosal artery.
Circumflex, yes.
So both the bulbar arteries are sacrificed while mobilizing the bulbar urethra routinely. And
yes,
you are also sacrificing the perforators while mobilizing the bulbar urethra from the cavernosa. So now
yes, sir.
What is the arterial supply of this flap?
So this will be solely depend on retrograde flow, dorsal penile artery, sir.
Dorsal penile. So the anterior urethra has got bipedal supply. In the operation, we are sacrificing the retrograde flow, this antegrade flow.
Yes, sir.
So this is very important.
Right.
And
very
how
important.
do you take care of it? What are the other structures which you have to protect while taking, while ligating or fulgurating these vessels? What other structures must not be injured?
So the adjacent nerves,
Yes, nerves are there. So some people prefer to fulgurate it, not take stitches. Otherwise, nerve may be entrapped in those stitches.
So very rightly pointed out that you have to be very careful that you do not injure the dorsal artery of the penis. So when you're doing an inferior pubectomy, you have to be very careful that you do not injure the nerves and the artery. So you know exactly how to do an inferior pubectomy. You just first incise the periosteum and then lift the periosteum and then do the osteotomy, and so that the arteries get retracted on the lateral side. And if you get the vein in the dorsal vein of the penis, you have to ligate that vein, right? That is important.
Right.
Anything else? Gautam?
Redo case, then you have to be careful about the when you're trying to lift the bulb of the perineal body. You have to be you have to put a finger in the rectum if it's a redo case. So that help in dissection of the.
Right.
How much scar you remove from the proximal margin, from the prostatic apex side?
Sir, until I identify the proximal urethra, I have to remove the scar, sir. Till then.
So it should be removed circularly or on a lateral edges only or all around? How you do it?
Anterolaterally, sir.
Okay.
Mostly, sir.
And you leave the thing in the lower part. You leave it.
So you have just to remove the scar over the apex. And while incising the prostatic apex, what precautions you have to take?
Sir,
You have
to take urethral.
You have to take the stay sutures before incising it, or just after giving a small incision, because epithelium may retract proximally, and then mucosa to mucosa approximation will be difficult, leading to restructuring, or it may be a part because lead to technical failure of the
ways of doing that. Actually, some people say that the mucosa should be everted first with sutures.
Yes.
Since I have been trained by Dr. Sanjay Kulkarni, we don't follow that, and we straight away go ahead with the end-to-end anastomosis.
Right. Yes. So yes,
it is
Dr.
not
Kulkarni.
it is not necessary to evert it, but at least it must be in the stay sutures, because sometimes it retracts proximally, and then mucosa to mucosa, epithelium to epithelium approximation may be difficult. What I feel.
Yes. Yeah, I agree, Dr. Rajesh. We are doing many times in that way only. But what Dr. Kulkarni does is that he first passes the hair group, sees and just incises over the scar tissue only, and then later excises the scar tissue on the anterolateral sides. And some people, like as you said, would be first excising the scar tissue and then open it up. So the two techniques people are doing it. I think both are correct in their own way. There is a question that if you are not able to pass the Hay groove dilator through the bladder neck, what would you do?
I will use then flexible scope, sir.
Okay. So if you pass a flexible scope, then how would you identify the proximal extent? So with the flexible scope, you would not be able to palpate, right? It's not that stiff or rigid.
Light off.
But if there's a scar tissue, it's very difficult to see the light with that scar tissue.
Sir, with the help of, there is a technique, sir. That is known as Jalil-Hussaini technique. We put a spinal needle or a large ball needle through the perineum, and we can see through the scope, sir, and integrally.
Right. So you can see whether it is passing through the bladder neck area or not exactly, you know? So yes, and then you can maybe incise over that. And then suppose you don't have a flexible cystoscope, you don't have that kind of thing available, and you're not able to pass through the bladder neck. It happens once in a while, right? So what will you do?
So then I can open the bladder and put a finger. And over the finger, I can incise.
Yes.
Very right.
Yes.
Correct.
It is very important.
Very important. Yes.
You have to assure yourself that you are in the right track, because we have seen the cases bulbar urethra being anastomosed to the false tract.
Right. So what are the precautions that you will take that you are not anastomosing with the false tract or not the right proximal urethra? What are the steps that you would ensure that you are joining to the right urethra? Sanjay?
Sir, when I incise, yes, sir. When I incise the proximal urethra, then I have to confirm that I am in the right place, sir. So for that, I have to look with the scope, sir, that verumentinum is there or not, sir.
Yes.
Right. So it's very important that you do scopy and see that you are anastomosing to the right proximal urethra. There's a question that any experience of crural rerouting. So I would ask our invitees, do they have any experience of crural rerouting?
No. I have no experience.
Okay, in 11 years,
I've never practiced.
Yes.
I put the number, but I've never done that. I've never done that. Yeah, up to pubectomy and transabdominal, we have done that.
Yeah, most of the times you are able to do it. We haven't come across a case where a crural rerouting is required, or it is a very kind of a severe kind of effect when there's a bulbar urethral necrosis, then you have to do a kind of interposition flap and all that thing, or you may have to go abdominally and do a kind of transpubic, which is usually almost obsolete nowadays. But I've just seen Tony Mundy doing it in one of the workshops. So Mundy definitely does it at times, and he has shown that you gain about 1 to 2 centimeters after doing a rerouting.
Is the patient in which the bladder neck is also injured. So in those cases, only you now need to do a abdominal approach as well as the perineum.
Yeah, that's true. So if there's a bladder neck injury, definitely bladder. And if a redo case when you have when it goes the prostatic urethra till the prostatic urethra, and sometimes you have to do an abdominal approach to reach the urethral end. Yes. Is there any different technique to? There's another question. Technique to end-to-end urethroplasty, or patients with hypospadias with PFUI. Is there any difference if the patient is supposed was hypospadic?
Yeah, so the problem that can come in a hypospadic is the blood supply.
Yes, Sanjay, first tell us. You tell us exactly. What will be the problem?
Sir, the limit of our bulbar urethral mobilization will be the problem, sir. It cannot be extensive bulbar urethral mobilization. It should be limited, sir, and we have to depend on other ancillary steps more than bulbar urethral mobilization.
So why do you want to keep the bulbourethral artery intact, at least one side, at least, or maybe a bilateral also in hypospadic urethra?
So because retrograde flow is already compromised, sir, in these patients.
Retrograde flow is not, because there is no corpus spongiosum, right? The corpus spongiosum, because what retrograde flow is actually basically dorsal artery of the penis, which is supplying the glans penis, and through the glans, it is coming to the corpus spongiosum, right? So that is the usual supply, which comes through that route. So if you do not have a corpus spongiosum, the urethra is devoid of that kind of blood supply in hypospadic meatus. So you have to be very careful, otherwise you will cause a full necrosis of the urethra. Or in your success would be, you probably would fail in the anastomosis. Anything else, Dr. Rajesh and Dr. Gautam?
In hypospadiac or complicated PFUIs, you can go for a staged repairs also, not single stage repair. You have an option of a staged repairs also.
Yes.
Whether you can tuck in a scrotal skin by Turner-Warwick method, as suggested by Turner-Warwick, and you can go for stage operations also.
Okay. Yes, so rightly pointed out. Then I think we can just go to the complications. Sanjay, just tell us what could be the complications during surgery and after post-operatively.
So during surgery,
one
so
thing
there is a
you
risk
can ask Dr. Sanjay.
8 minutes. Stop. Sanjay, stop, please. Rajesh, go
Sanjay,
ahead.
you can ask that where you put the drain, whether you put drain or not after the operation.
Sir, we used to put up drain, sir.
At what level? In which layer? Put a drain.
Sir, after closing the bulbo-spongiosum muscle, sir. Sorry, yes.
After closing the
Bulbo-spongiosum, sir.
or just over the anastomosis or above the bulbospongiosum?
So would it change? Yes, tell us. Yes.
Sir, if I put the drain close to the anastomosis, then it will irritate the anastomosis and may impair the healing, sir.
And more importantly, why Dr. Rajesh is asking you, more importantly, what will happen?
Basically, sir, if the anastomosis is leak, then continuously it will not heal, sir.
Right. So there will be urinary leakage and siphoning of urine through that particular drain side area. So you usually put the drain above the anastomosis, not on the anastomosis. That is correct.
Dr. Sanjay,
what do you practice to reduce the tension on the anastomosis? After doing the anastomosis, what steps do you take to reduce the tension on the anastomotic line? Do you do something for that?
Sanjay, what do you do? Do you put any sutures somewhere to reduce the tension?
Sir, we put both the carporal sutures after doing the anastomosis so they can pull proximally, sir. So it will help to reduce the tension, sir.
What are the causes of technical failure? One complication is restructuring. So what could be the causes of restructuring?
So the main causes are when we put the anastomosis under tension, sir, and if the patient had previous bulbourethral injury, sir, bulbourethral necrosis. If we inadequately excise the scar, sir.
So you can divide into two divisions. One is technical failure, another is vascular origin, ischemic origin, which leads to penile necrosis. Okay, you can continue, sir. Dr. Sivam.
Yes. So very importantly pointed out, technically, if you are not sound, you have not done a mucosa to mucosa anastomosis, or it is under tension, or you have, so that could be one of the reason. And another is if there is a loss of blood supply to that area due to any reason. So that can cause a ischemic area and anastomosis failure.
And you can differentiate it between the two. The technical failure one is short segment, annular strictures, these strictures. And the penile necrosis one is the longer.
The vascular failure would be usually a long. And sometimes the whole bulbar may necrose. Yes, right. Very rightly pointed.
How many sutures do you give for anastomosis? How many sutures do you take?
Sir, we used to do 6 sutures, sir.
Which suture?
Vicryl 40, sir.
Vicryl 40 and 6 sutures. Okay.
So many people would put 8 sutures, some 12 also. Mandi puts probably 12 sutures, but I think most of us in India put 6 sutures. Yes. All right. So go ahead, Gaurav. Gaurav, show us the next slide.
So next slide for probable complication of progressive perineal erythroplasty. Firstly, we see the intra-op complication, injury to anterior urethra, and there is 3% chance of rectal injury and chances of injury to dorsum of the penis. Now come to early post-operative complications.
I just stop. This dorsal nerve or dorsal artery of the penis can be injured, right? So that's it. Go ahead.
Yes, sir. Then come to early post-operative complications. There will be bleeding, wound infection, or scrotal edema and epididymoorchitis. And in delayed post-operative complication, there is 15 to 30% chances of restricture and anastomosis to false lumen, erectile and ejaculatory dysfunctions, and incontinence.
So Sanjay, what is the chance of having a de novo erectile dysfunction after urethroplasty? Did you understand?
Yes, sir.
Sanjay, yes, de novo. That means the patient was normal, had normal erection before, but now after urethroplasty, he has a poor erection.
So 15 to 20% chance.
No. It's not to that. Usually, urethroplasty would not cause erectile dysfunction, or it may sometimes improve the erections also. Improves in the terms of like sometimes the fibrous tissue when you exercise, it releases the nerves sometimes and can improve the erectile function. So, but still you can have some erectile dysfunction that is 2 to 5% below. So in some studies they have shown there may be a chance of 2 to 5% chance of erectile dysfunction below. Yes. Should we go ahead? Yes.
A year to
Yes. Gautam? Yes.
So you have to wait at least a year to define that ED. We have to wait. You can give penile rehabilitation thing and
Right.
come to conclusion immediately. Sometime post-surgery, patient can have some amount of erectile dysfunction, which improves over a period of time.
Right. So there may be a kind of temporary or transient neuropraxia or something which can cause a temporary erectile dysfunction, which will improve over time. That can, and sometimes a psychogenic, when the patient has overcome the stress of the operation and everything, then that also is overcome over time. So the patient may improve, and the penile rehab can be done with either PD5 inhibitors or all those things in these patients, right? How would you again follow up these patients, right? So we come to the end of almost this case discussion.
One point is very important.
Yes, Dr.
One point is very
Rajesh.
important. Suppose patient has rectal injury at the time of operation. What will you do?
Sanjay.
Sir, I will do colostomy, sir.
Every case?
Sir, if I'm worried about my
the operation, or we will do the stop the operation, repair the rectum, and do colostomy, or not doing colostomy, completing the operation. What will you do?
Sir, after completing the operation, then I will proceed for colostomy, sir.
In all the cases, as Dr. Siva has asked.
Every case requires a colostomy. Sometimes there is a very minor injury to the rectum, and you have a full bowel preparation, enema was given, everything was good. So in that case, also in every case, does it require a colostomy?
In minor cases, minor injury, then I can.
So you can even close the injury if there is a minor injury, and then you can, if you are very sure about your anastomosis and everything, technically you are very sound. I think it's not necessary in every case doing a colostomy. Yes, but yes, if you are not very sound and technically, and a rectal injury is a kind of major injury, definitely.
Okay. Right.
Yes, Gautam, anything?
Try to put something in between if you can get some local tissue. Or if
very right, yes.
Yeah, so anything interposed between the thing can solve the problem.
Right. So if you can put an interposition flap, there's a chance of developing rectourethral fistula would be minimum later post-operative. Yes. So follow up. How will you follow up these patients?
Yes, sir. Sir, I will advise patient to follow up after 4 weeks. After at 4 weeks, I will remove the catheter and clamp the SPC and advise patient to maturate. If he maturate well, then I will advise patient to go home and again told him to come at three months.
No, there are two.
Then
problems.
6 months and then 1 year.
There are 2 points.
And
hold on.
Sanjay, hold on. Let Dr. Rajesh.
You will remove the SPC without any radiological investigation, or you will do. And when you will remove the SPC? After a few days of removing urethral catheter, even if he is voiding well, or you will remove at the same sitting. Just see the X-rays.
Sir, I will remove.
Yes.
Sir, we used to remove after 7 days of clamping, sir, if patient voided well.
But you have not mentioned, that's why I asked.
It's very important point. Usually, most of us would wait for a few days, maybe 2 to 7 days at least. If the patient is voiding well for 7 days, we are sure that the anastomosis has been good and set, so we can remove the SPC. Right, very important. So when would you
suppose there is a leak? Suppose there is extravasation of contrast at the anastomotic site. When you are doing MCU, what you will do?
Sanjay?
Sir, if the amount of extravasation is very little or minor leak is there, sir, then I will just open the SPC. And if the major contrast extravasation is there, then I will plan to do a scopy and put a catheter, sir.
No, but when do you do RGO? With the catheter in or after removing the catheter? It's a pericatheter ureterogram, right?
Yes,
so
sir.
if you are doing yeah, pardon?
Sir, if my surgery is very complex, sir, and I am not sure about my anastomosis, then I will remove the catheter after pericatheter ureterogram.
Right. So we do a pericatheter ureterogram, and if it is showing leak, then you will keep the catheter for a prolonged period. So we'll keep the catheter for 1 or 2 weeks more, right? So that's what Dr. Rajesh was trying to ask you, yes? So if you have a leak, then you keep the catheter inside for 1 or 2 weeks more, and then again do maybe a pericatheter ureterogram or remove the catheter if it was a very minor leak. Yes. Anything else, Dr. Gautam and Dr. Rajesh?
So how do you follow up these patients at 3 months and 12 months?
Sir, at the follow-up periods, we used to advise patient that is score uroflowmetry, sir.
Okay. And then what are the parameters you see in a uroflowmetry, which gives you an idea that the patient is doing fine?
So uroflowmetry, if it is less than 15 ml, Qmax is less than 15, then and the symptom is score. Both are correlated, then I will do RGU MCU, sir.
Qmax or the pattern on the uroflow which matters? Is just one Qmax which is important, or the graph which you get in a uroflowmetry, which will give an idea whether the picture is
yes, the graph is also important, sir. Both Qmax and graph.
Because the patient strains hard, very hard, then the Qmax can increase up to 15, 16 also. But actually the Q average or the continuous graph pattern is more important, which will give you an idea whether the patient is having a recurrence of the stricture or not.
I think very rightly pointed out, Sanjay, sometimes you will see in the uroflowmetry an artifact. Initially, you will get a peak and the computer will tell you that the Qmax is around 20, 25. But the actual graph, you will see there's a very blunted kind of graph, right? Stunting of the whole bell curve. So that would be could be an artifact also if you just see the Qmax without seeing the graph. So it is very important that you see the graph, actual graph. Right? So there you would be able to know what is the actual Qmax and what is the average flow and whether this patient is voiding well or not. It's a very important question. I think we have almost crossed our time limit. So, I will request our moderator, Dr. R.D. Sahu. R.D. Sahu, please come in. You unshare Gaurav. R.D. Sahu is there? R.D. Sahu, please unmute yourself and give the vote of thanks, and then we will just wind up.
And on behalf of our department, I convey my sincere thanks to our invitees, Dr. Rajesh sir, Dr. Santosh sir, and Dr. Gautam, for sparing your for their valuable time. Thank you, sir. Thank you very much, sir.
Thanks, Adi. And thank you once again from the Department of Urology, SMS, Dr. Rajesh Tiwari and Dr. Gautam Banga, both of you. And if Dr. Santosh has joined, of having spared a very valuable time and giving us the privilege to participate here. Thank you very much. Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you and good night.
Good night.
Thank you, sir.